Good morning, everybody. At the outset, I'd like to thank Dr. Khanna and the Apollo Hospital Group for inviting me and giving me an opportunity to speak today. We're having some problems getting my presentation going. I'm going to speak a little bit about stem cell in peripheral arterial disease and role of regenerative medicine is basically, it's been rekindled now. It's been rekindled in recent times, and it's been looked into as a major source of furthering our knowledge and therapeutic potential for patients with, by and large, non-correctable, non-reconstructible lesions. And I'm not just talking about arterial disease, I'm talking about things like spinal cord injury, congenital problems. So regenerative medicine is the next frontier, and what we are doing, I'm at the Escort Heart Institute. Come down, नीचे 19th का काम ये निकाल ये और इस एक फिल्म भी है रमेश कुमार की फिल्म. So what we are doing is we're doing a phase 3 study, and it's ethics committee approved, ICMR approved study. What we are using is bone marrow derived stem cells, and we ultracentrifuge them and we re-inject them. The point I think that needs to be emphasized and re-emphasized is patient selection. As we all know, I mean, we are having a discussion on vascular intervention, vascular surgical techniques. We must appreciate that every patient or every technique is not feasible, not possible for every patient. Similarly, same modality cannot be used. So therefore, we must segregate our patients. And that's where I think ICMR is leading the way, and it's giving some very good guidelines. And I think they should be coming in print very soon. What we try to do is we try to subset our patients to see what is non-reconstructible peripheral arterial disease. And when we talk about, thank you. When we talk about this page down. Okay, and what about the angiogram? Will it come on its own? Okay, right, thanks. Right, okay, so I get going. Thank you. Pluripotent undifferentiated cells. Basically, we are using the reserves of the body, the cells that build the body, and how we want to regenerate them, and we try to change what the local milieu would be at any particular point, and we try to use those cells. This has been, it's not a new concept, it's been tried over 25, 30 years ago, it's still being tried, but people are understanding the biomechanics, they're understanding the biochemistry, the signals that are required for a particular cell type to go down a particular cell line. So we have basically two types of stem cells. So what is a stem cell? We're looking at very embryonic, very basic cells. So we have two basic types, the embryonic type, the adult type. The embryonic type is what is known as totipotent. That's how a baby is born. So basically they can produce anything. So we are looking at the embryonic cell types, which unfortunately are not really available for therapeutic use. Although now cord blood is being used, it is being used for certain level of this thing, but it is not ethically approved to be used in every form of therapeutics. The second is the adult cell type, which we can have access to. And those are the cells that we try to, and they're multipotent. The downside here is that they cannot produce another human being. So therefore these cells can produce certain amount of things, and then the rest of it is, we have to see how they go down which line. Now, as I said, embryonic can differentiate into any cell type. Ethical issues are existing, and there are centers, particularly in India, because we have in many ways unregulated practice. In many ways, some people are using the cell lines derived from fetuses, but it is not ethical and not approved. However, adult cell lines can be used, but they cannot be cultured easily. They become a little bit more difficult to really get into a particular cell line, but they can be auto-transplanted, and there is no real immune response in the form of rejection. Now, the advantage of adult cell type is that they differentiate into narrow cell lines. So we look at liver regeneration, we can look at bone marrow regeneration, actual cell lines. That means we can have WBC lines, we can have RBC lines, we can use platelets, and we can also use neovasculogenesis. And this is a phenomena that has been found when this was in vitro studied, and found that when we put the local milieu, when the trigger is different, the cell goes down a different cell line. And this is what is trying to be exploited into what we are trying to use in peripheral system, and to some extent people are also trying to use it into the coronary system. Now, other sources, as I said, there are umbilical cord cell banks today which are very good, very advanced. They are using it. In fact, it is picking up even in our country. It is expensive, it's private, but they are good quality FDA approved facilities even available in Delhi, which I'm glad to say we are also associating with a very top class facility in that sense. They're also multipotent, they can be processed, and also adult cell types as well as of course the umbilical cord, they can be cryopreserved. So if during the process of really centrifuging them, if they are put into cryopreserve, they can be preserved. The advantage that we use, particularly in our study for this, is that we can use these cells over a few days. So I don't have to, as soon as I get them back from the lab, we don't have to inject them in say 24, 48 hours, which we normally would have to. If it's cryopreserved, you can keep them a little longer, but you have to inform the lab accordingly prior to actually getting them developed. Now, when I'm linking the two things, now that was some amount of science. I'm not really a scientist. I'm a guy who does clinical work by and large, but this is my research interest. So why are we linking this? What are we looking at? Now, we find as vascular specialists, we find we do have a clinical subset of patients who we cannot help by direct therapeutic means or evidence-based, so to speak, therapeutic means, by which I mean intervention, surgery, whatever else is now evidence-based. So when we talk of peripheral arterial disease, we're looking at similar sort of disease processes as occur in the coronary system, maybe in the cerebral system, and the medium-sized arteries, and atherosclerosis obviously has a role with the usual sort of risk factors, and our patient bank is the same as really the coronary system. Patients with cramping pain, patients with intermittent claudication, they don't really fall in the group here. So we are looking at patients with critical limb ischemia. So we're looking at patients with intractable rest pain, we're looking at tissue necrosis, we're looking at patients with ulcerations, so limb at threat. So in broad terms, we're looking at patients with limb at threat, and those are the patients that we try to still segregate further, whether they are reconstructible or they are not reconstructible by evidence-based means. And that's an important question, and that's where we are finding ourselves more and more. I would say that the defining criteria are coming out even in our country, and which is very, very important, because like everything in India, there are all this potential for things to be misused, particularly when there are financial implications involved and patients want magic. So when when people providing therapeutics, they start giving magic, then patients start thronging to them and they get misled. So how do we diagnose PAD? I don't want to go into the details. I think everybody would know about this, a Doppler study. Of course, we have to go down to an angiography, and we have to understand that these patients have to be segregated only after an angiography is done. Therapeutics, as far as treatment is concerned, we have clear-cut, we have to modify the risk factors, we have to give the usual advice to the patients. We have very good interventional techniques, very standard, very evidence-based. I would say today interventional techniques in vascular therapeutics are at every level. So there was a time, I would say 10, 15 years ago, when infrageniculate work, particularly interventional work, was not very evidence-based, but today it is very much evidence-based. The technology has come up. We have catheters, we have wires, we have very good, I would say, balloons. Stents, particularly drug-eluting stents and all in infrageniculate position, don't have evidence base as of now, but things are developing fast and they will come. So technology will catch up. So intervention will be a very big mainstay of treating our patients. Of course, there will be costs involved, and re-procedure is a downside for intervention. Surgery, of course, I'm a surgeon, trained surgeon. I would love to do surgery wherever possible, but we need to understand where our limitations are, what we can do, what we can't do. And therefore, again, patient selection is a very, very important way of course, conduit, and what type of conduit every good person who's providing care should be knowing what needs to be used at what position, and therefore we can do. But what do we do for patients like this? Now, this is a 36-year-old gentleman. If I can get the angiogram going. Is it possible? There's a sub-file on the angiogram, please. 36-year-old, heavy smoker, says he's a reformed young man, productive person of his family, Indian, not much money, wants magic. And we do this angiogram. Now we see that the proximal vessels, so to speak, are very clean or relatively clean. And then infrageniculate level, he has a very poor peroneal runoff, which also doesn't really make it to the lower third of the leg. Now, this is not bypassable. We cannot bypass on principles. Why? Because we cannot increase perfusion really at the foot level. So putting a wire down the peroneal at this level would not be a good idea, because the peroneal really doesn't make it to the foot, even in normal anatomy. So if you put a wire down, there's a very high chance you dissect it, and that would not be a good option. Now, I would like to see anybody with good interventional techniques trying to put a wire down the AT or maybe the PT, which don't exist in such angiograms. So these kind of patients, and young patients, productive patients, I wouldn't say this angiogram is typically thromboangiitis obliterans, but yes, we can say this is cigarette smoke or tobacco smoke induced problem. How do we treat these patients? Now, we have particular problems. These patients cannot afford expensive therapeutics. They cannot afford expensive hardware. So we need to give them something that works. And therefore, these are the patients that we want to put into our study. These are the patients, thank you, that we want to consider for our study. So this is a non-reconstructible PAD as per definition, our inclusion criteria. We don't think any form of standard evidence-based treatment is going to work. And then sometimes we find patients, they don't have suitable conduit. So infrageniculate reconstruction, which is really a very, very good way of treating patients, you need natural conduit. You need vein. If you can use good vein, you need to use vein. If you can't, then okay, if you have some arterial conduit, you can use it. But it's not the standard way for peripheral circulation. We try to use vein. So we have limitations. Now, what really do we do for these patients? Of course, we work them up, we bring them into the hospital, and then we do the bone marrow aspiration, we centrifuge that, cryopreserve it, and then we re-inject it. As per our study, current study, or the original study that we started, we were doing angiograms and then re-injecting through catheters, and therefore that was one way of doing it. But we then went ahead. These are some of the results I'd like to show. I'm going a little short on time, so I'll just go quickly. We've done about 14, 15 cases. The data is still being studied, so I cannot show you preliminary data, but I would just say that some of the patients do very well. We have about 60 to 70% good response rate, and this is what critical ischemia is all about. You want patients to go back with functional feet. I don't say that we create two pulses at that pedal level, but we send them back with functional foot. Now, the functional foot means that there should be a heel, and the patient should be able to stand. This is that patient I showed you, Ramesh Kumar. We managed to salvage him 6 weeks later. Can we just go back? Okay, time is up. I just want to go and say, just one slide. We have modified our study now as per the Indiana school now. We do inject locally as well. So we have two arms as our study comes down in therapeutics. Patients with ulcers, we try to inject around the ulcers. We have specific criteria. We go 1 centimeter apart. We dilute it. And I think that's also giving us good results. So in summary, ladies and gentlemen, I would like to just say that peripheral vascular disease should be diagnosed early. Direct revascularization obviously is the first thing that whatever we can do. There is a definite subset. The importance that we recognize them. We need to refine this technique, but it is extremely promising. Regenerative medicine is the way forward. Thank you very much for your time.
Thank you, Dr. Ashok, for a wonderful presentation. And he has enlightened us that how the embryonic resources and non-embryonic resources of stem cells can help us achieve our end, and how the treatment from it has the technology of stem cell therapy has grown from an expensive and exciting and experimental field to an effective, easy and inexpensive field. And a great challenge was actually how to reconstitute the tissue. Let's say there were hematopoietic reconstitution. We know the standard doses of stem cells. Let's say the mononuclear around 300 million cells per kg of the recipient are required for either bone marrow or peripheral blood. And for the cord blood, around 30 million cells per kg of the recipient are required for hematopoietic reconstitution. But as Dr. Ashok Gupta has told us, that it was really a challenge to know what amount of hematopoietic tissue is there to reconstitute either neural tissue or cardiac tissue or vascular tissue. So this is how by doing the clinical studies we can know and how much amount of this tissue is required, stem cells is required to really go ahead. And I think by this great learning there is a way forward. Thank you, Dr. Ashok. If there is any question from the floor.
Ashok Dhar from Calcutta. Now, Dr. Gupta, what you have mentioned I'd just like to make a point about this, that you have shown below knee vessel problem. It is very common in our country, particularly among the younger group of people, those who are smoking bidi. And that up to the knee, up to the popliteal, it is fine. Below that is disastrous. And now, but I don't agree with one thing, that without trying for intervention, just go for stem cell. No. Well, there are cases, I mean, it should be tried to recanalize and build up one channel. If you can build up one route, that is either posterior tibial or anterior tibial, that is enough. As adjunct along with it, yes, stem cell therapy is very much acceptable and should be done also where it is available, as it is in your hospital. But not to leave that okay, ye hoga nahi, and you just go on for stem cell. No, because there are various different techniques now have come. Say, for example, if up to the approach, it becomes very difficult to go up to the toe with your endovascular techniques. But what is there, that if up to the popliteal everything is fine, puncture at the ipsilateral femoral artery and you can go down. Even after, besides that, you can always get a lumen from the posterior tibial artery at the foot. You can puncture there and go in a retrograde way, and you can open that. And so I believe that one should try definitely and sit all together, do that, and along with that your stem cell. Together, that will bring
May I
success.
respond to that question?
Michelle, you agree with it?
May I respond?
Thank you, sir.
Thank you very much. I was expecting somebody from this illustrious audience to bring this point up, and I'm glad that you brought it up. 2 points. I understand ipsilateral puncture and what we're talking about. We're talking about occluded vessels. We're talking about single time that we need to do something for this patient. Patient is not going to come back for reintervention. As far as retrograde, yes, sure, it's a good technique, but not again in an occluded vessel. Occluded posterior tibial, again you will dissect retrograde.
We are not being able to see it. We do not know whether it doesn't exist. That thing should be done, and I am telling you because, well, I'm in this job.
Mm-hmm.
And already, though we do not get much support in our country, because still people are having with sympathectomy and all those things in these cases, but I can tell you more than 80 cases experience, and so there are failures, but I have reconstructed really up to the dorsal since after that 7 or 8 years I have followed up, they are doing well. So my point is only that one should sit together, discuss about it and try, not that okay, let us go only for stem cell. And both these together, they can definitely help the patients a lot. And
right.
It is available in your hospital. Unfortunately, I do not have this facilities, and I would have loved to have your assistance of people like you, so that these two together, that could really help the people.
We do that. We do that combined as well, but we do select our patients. And I think this particular angiogram, I do not believe that we should try anything with a wire. We should just do that.
Exactly, that's what I would like to say. I have seen that, and that type of cases I have done, sir.
No,
that is
anecdotal.
From Dr. Ashok, I'll rephrase his question from our practical view of the audience, that I'd like to know, is there any studies where stem cells has been used upfront and without failing any technique? Because essentially we want to know the failure, is it must? Or Dr. Ashok can tell us where there have been studies where stem cells has been used as first and only treatment.
What Dr. Dhar is saying is a point well taken. We have used them in conjunction as well. But I would still suggest in these patients where we know that there is really nothing, if I can see a stump of any tibial vessel, I would be more than happy to go down with a wire and use any platform over the wire, which I'm quite happy to use myself. I don't have any issues. I don't need anybody's help in that. But the point is, if I don't see a stump of a vessel and you start dissecting vessels, particularly tibial vessels, whatever option you have left, even in stem cells, because if the patient has critical limb ischemia, if he has rest pain, next thing he's going to ask after dissection is, please do my amputation. So you're not going to be able to take 300 cc of his bone marrow and convince him that he needs to spend more money to get his bone marrow aspirated and implanted. So we have to look at, yes, I take his point that he doesn't have a bone marrow aspiration, he doesn't have a stem cell phase 3 study going on in his institution. So he's at a center where he has to provide an answer. So he's providing an answer. But is that evidence-based? He's anecdotal. He's not evidence-based. So when we look at evidence-based medicine, here we are trying to make evidence-based criteria. I'm trying to go down to what ICMR is saying. So we have to come down to ICMR.
Then we'll have now next question from Dr. Mahajan.
It's not anecdotal. It's not about me and him. It's about what the patient, what's best for the patient.
One question from Dr. Mahajan, please.
One last question, or rather a point. You are dealing here with a desperate cohort of patients. One thing I wanted to say was that how about boosting the peripheral blood by giving growth factor and getting it from peripheral blood?
Yeah.
The yield is higher and just inject it locally into the muscles, by which you can reduce probably the cost as well, doing it as an outpatient rather than admitting the patient. It is slightly less invasive.
I agree. That's a very good suggestion. People are doing it. Tarun is here. Gangaram is doing peripheral blood based. But one thing, it's not cheap. Secondly, the thing is the yield. This is contentious. Yield from bone marrow, yield from peripheral blood post growth factor is contentious, whether it's higher or not. So if it's a good bone marrow, particularly young, healthy patient, you will get a very good yield. And I haven't gone through the details, but we do CD34 markers. We look at what kind of marrow we have, what kind of quality of stem cell we are injecting. It's all studied. It's all documented. So therefore, I would not say it's a way forward. People are doing it. Like we are the only people in Delhi who use bone marrow. Gangaram is using peripheral blood. RR has recently been approved by ICMR to do peripheral blood based with growth factor. It's a good way forward. They have good results as well. But the yield is higher, is contentious. B, cost is lower, also becomes a little contentious because most of these are being supported by companies. So if the growth factor has to be bought by the patient, then it's not going to be cheaper. Tarun, you got a question?
Okay, thank you, Sir Gupta.
Just, it's a very good talk, but I would sort of agree with Dr. Ashok Dhar also, because even in our institute we do not have a lot of experience with the stem cell implantation, although we have some experience. But what we have done is many cases like this, the angiogram which you showed, we have done subintimal angioplasties all the way up to the foot, the tibial vessels and down up to the foot, And the patients, we've got follow-up. Dr. Bera is right on on the chair position, and we've done follow-up with CT angiograms after 1 year, and these patients have done very well and with no amputation. So we should actually try this in centers, at least if where the bone marrow is not available or the stem cell is not available, and many a times this really works.
I agree with you. I think that's a way forward.
Can I make a comment, please?
Tarun's got a question.
I'm Dr. Tarun. I'm also a vascular surgeon. I just want to make a comment where we are talking about, I totally agree with Dr. Ashok, because these patients, when we are talking about these patients, when we categorize them as non-reconstructible, we mean that no angioplasty or no surgery can be done. We are talking about subintimal angioplasty or infraoperative angioplasty in patients who have diffuse atherosclerotic diabetic disease or a peripheral vascular disease, but not this inflammatory vasculitis because of thromboangiodentis obliterans. There is no way that you can create a lumen in this because there is no lumen in these vessels. It has been well proven that these young patients, especially 28 years, 30 years, if you pass your wires, there is no lumen, there is no subintimal plane. It is a concentric fibrosis of these vessels. Histopathologically, it has been well proven. Later in the afternoon, I'll show my series of subintimal angioplasties and infraoperative angioplasty, but all these group of patients are elderly patients. Young patients, I don't believe that you can pass a retrograde wire in these patients who suffer from Berger disease. If anybody has experience of doing angioplasty, retrograde technique in 28 years old patient or for some sort of another pathology, it's fine, but not for TAO. I don't agree to it because these are corkscrew collaterals. There is no continuity of the named vessels in these patients.
Okay.
Thank you for valuable session. Thank you, Dr. Asogupta.
Thank you very much for your time.
At the end of